Gracias, Jorge, por este gran placer de regresar aquí a Argentina. En 1992 yo vine a dar una charla de angioplastia en infarto agudo y mucha de la gente pensó que yo estaba loco. ¿Cómo vamos a hacer angioplastia en infarto? Pero ahora hacemos cada los días. Tal vez después de esta charla ustedes también van a decir, y todavía es loco, pero le voy a dar una nueva charla de otro modo de componer la válvula aórtica. I'm going to give the lecture in English. Pardon me for doing that, but I think it'll be easier and the translators will have less difficulty too. The work that I'm going to present to you is a new way of putting transcatheter valves into the heart. And again, this is a technique that we've pioneered at Henry Ford Hospital with my colleague Adam Greenbaum and Robert Letterman, Myra Guerrero, and Guy Payone. In the United States, the sheath sizes are very large. We had the early devices required sheaths that were up to 9 millimeters in diameter, and so the femoral vessels in particular were very difficult to get into. And so many patients could not have aortic valves implanted through the transfemoral approach. Transapical and transaortic approaches were developed, but these have some difficulty attached with them with significant morbidity, especially with the transapical approach. So we sought alternative means of getting the valves in. Now, one area that we've worked on for a long time is the femoral veins. The femoral veins are large in caliber, the vena cava, and also are very pliable, so that you can enter the veins. In fact, Alain Crivier, when he first developed the transcatheter valve program, started to do it in an antegrade approach, going in from the IVC across the right atrium, around the ventricle, and up into the aorta. We tried that technique also, but it's very, very difficult to do, and it's been abandoned because it's been so hard to do. But the veins are a very interesting conduit, and so the simple idea is why not go into the vein and then across into the abdominal aorta? And that was the concept that we really wanted to pioneer. Dr. Robert Letterman at the NIH had done this successfully in a pig model, but no one had tried it in humans. And you would think the biggest worry is that when you go into the aorta, if you puncture the aorta and have a tract, that you would create a massive retroperitoneal bleed. And that's really the largest concern that people had when this technique was being done. The interesting point is that the pressure in the interstitial space is actually higher than it is in the vena cava. So that if you have a path between the aorta and the vena cava, you will always have an AV fistula. You won't have a lot of bleeding in the interstitial space. The blood will actually go from the aorta through the interstitial space and into the vena cava. So this provides a safety because at the very worst that can happen, you'll have a very large AV fistula, but the patient won't exsanguinate. Now that's the theory. No one had ever tested it in humans. And so we were presented with this first patient. She's a 79-year-old lady. She'd had a previous prosthetic aortic valve implanted, but this valve decompensated. She had severe aortic insufficiency. She was in class 4 heart failure. She had a porcelain aorta, so the transaortic approach was not possible. We attempted to do a transapical incision, but the myocardium was so friable that the needles simply wouldn't hold, and it was not possible to do this from the transapical approach. So basically, this lady was in our hospital, and she was literally dying because of the severe aortic insufficiency. And so she was the first patient that we attempted the procedure on. Now, we do very elaborate CT planning. This is the CT scan, and you can see that this is the aorta, and this is the vena cava. And in fact, in most patients, there's only about a 5 to 7 millimeter distance between the aorta and the vena cava. And then we look in areas that are not heavily calcified to cross across the needle so that we can make access from the vein to the aorta. This is the equipment that's required. We learn from our electrophysiology colleagues that by putting a cautery device, so this is simply just a surgical cautery that we clip onto the back end of a Shinobi guide wire, and then we put the wire through a delivery device that allows access. This is a 14 French, an 014 guide wire, and that will go through and you'll be able to put a larger guide through it. So this is basically an angiogram that shows you the relationship between the aorta and the vena cava. And you can see in this particular patient, there actually was about a 15 millimeter difference between the aorta and the vena cava. Now, in order to go from the vena cava to the aorta, we have a gooseneck snare. This is sitting in the abdominal aorta, and this is a RDC, a renal guide catheter sitting in the vena cava. We look in two angles so to make sure that basically you've got, this is an AP view and this is a 90-degree view, to make sure that you've got the device pointing exactly towards the snare. And then the next phase is activation, and you can see that when we activate the snare, the wire goes through, and then we can grab the wire and then simply pull it up to make sure that now we've got a track. An 014 wire is through the vena cava into the aorta and up into the abdominal aorta. With that, then we're able to advance larger wires. In some patients, we've had to use a balloon to dilate the track. The wire goes up, and then we can put a very large, stiff wire through all of this. Now the guide, the sheath simply goes through, and you can see the sheath is now going through the stiff wire across the abdominal aorta. And that was the concern that we had, was that, all right, if you do that, then are you going to get massive bleeding when you create the track? And so for the first set of patients, we actually did injections through the sheath to show that there's no extravasation. And then we went ahead and proceeded with the implantation. The valve now is coming through, and the implantation is done as normally is done. This is what the closure looks like. So we take in this case it was a PDA occluder. We usually use VSD occluders that are made by St. Jude's. They're nitinol occluders, and we place those in place. And you can see that the patient still had a substantial amount of blood, but it was going from the aorta into the IVC. So an AV fistula had been created, but not a lot of extravasation into the aorta. And this is what she looked like on post-op day 3, and this is like 40 days out. So this is the first patient that we treated, dramatically successful. She was dying in our hospital and was with really no other alternative for palliation. This is what the track looked like before. This is day 3, and this is at day 42. So the track had entirely sealed by the 42nd day. And so this is the first patient that we tried it on, and it was actually pretty dramatically successful. There were a lot of things that we weren't sure about and we didn't know. And as we've developed the technique, we've got more and more comfortable with the procedure. First, the patients can tolerate the track creation. There's not severe AV fistulas, there's not severe hemorrhage that occurs, and the track can be very accurately closed. And so it really allows us a huge new opportunity for access for patients that have transcatheter valves. Now, these are the first 9 patients that were treated. You can see that most of the patients actually were women, and they were all very symptomatic with high STS scores. Most of them are women. Here are some of the reasons why we did a transcaval cath. The first patient, we had failed the transapical TAVR. That was simply not possible. The second patient was frail, immunocompromised, very small caliber femoral vessels. Here's another failed surgery where the patient had attempted open heart surgery, but the surgery could not be performed because of severe aortic calcification, small vessels, and immunocompromised. And so you can kind of see who these patients are. They're very ill, they're very end stage, they have no other treatment options, and these patients have by and large done very well. The other thing that is very counterintuitive and kind of strange is that you would think that putting in sheaths in very damaged aortas would be a terrible thing to do. And you can see that these are some of the vessels. There's a lot of aortic ectasia. There's some hematomas on the walls of vessels. And again, all of these patients have extreme amounts of calcium or aortic wall damage. But in spite of that, the seals have been very successful. Now, in the 35 patients that we've done, there have been 4 patients where bailout aortic wall graft stents were required, percutaneously implanted, and those were primarily when we weren't sure about the sizing of the closure devices. In the last 10 patients, we haven't had any need for having any kind of bailout stenting, and as we become more experienced with the closing, we think that the procedure will continue. The complications, one patient died, and this is a patient that had nothing to do with the valve implant, with a transcaval closure. The valve embolized into the ventricle, and we had to send the patient off to emergency surgery. We closed the tract, and then the patient went off to have heart surgery, and unfortunately died about 40 days later of multiple complications. One patient did have severe thrombocytopenia. That's quite interesting. It was the very first patient, and in the literature, when PDAs are put into the patients and the tracts don't close, there is some AV fistulas and thrombocytopenia that can occur. As soon as the tract closes, the platelet count came right back up. And these are the patients that have done so far. As I mentioned, that this is a new technique that is available now. It may offer an alternative for patients that are high risks. We obviously are going to need to have longer-term follow-up. Dr. Adam Greenbaum, the co-director of the program at Henry Ford, now has a NIH trial that is being done in 7 hospitals throughout the country. So the Brigham Hospital is being trained today. We've trained Oklahoma Heart Center, Detroit Medical Center, Emory University, and we're going to be training the Cleveland Clinic pretty soon on the procedure. So we think that this is going to be a very viable alternative and a new method of putting in these transcatheter valves. The thing that's very important is that all of the equipment that we're using is commercially available. Everything is off the shelf. There's no research equipment that's required, and certainly for anyone here in Argentina that wants to learn how to do it, we'd be more than happy to teach you, because I think it will be literally life-saving in some of these desperate patients where no other vascular access site is available. So thank you very much, Jorge, for your kind invitation. I really enjoyed being here, and I'd be happy to answer questions.
Vamos a pedir que me abran el micrófono y aprovechamos para charlar unos minutos, Bill, sobre esta técnica, no solo tu técnica, que como siempre es revolucionaria, sino cómo es tu perspectiva, cómo ves el lugar que ha ocupado el reemplazo valvular aórtico percutáneo, llamado TAVI, en la práctica, en tu práctica, en el contexto de cómo se arma esta Heart Team, en el contexto de la práctica regional y en Estados Unidos. ¿Cómo lo ves? ¿Cómo va evolucionando todo esto en tu manera de pensar?
Yeah, I think it's very important to think about three battles that have been waged. The battle of angioplasty versus bypass surgery, the battle of carotid stent versus carotid endarterectomy, and the battle of aortic valve replacement versus transcatheter valve therapy. And I think that we are much better at collaborating than at fighting with each other, and the patients are much better. In the United States, there's been a war between the vascular surgeons and the interventional cardiologists about carotid stenting. And as a result of that, there are very few patients that are being treated with carotid stenting. There's no innovation, there's no new devices, there's no safety. And basically the field is really languishing because the cardiologists and the vascular surgeons basically hate each other and rather worry about their turf than expanding the field. Now with TAVR, it's been a very different experience. The cardiac surgeons were very scared that they were going to lose this battle like they lost the battle for angioplasty. And so rather than fight it, they've actually embraced it. And so the cardiac surgeons have been partners, at least in the United States. The insurance companies mandate that the cardiac surgeon and the cardiologist work together. We have to have one cardiac surgeon and one cardiologist scrub in on the procedures, and if both don't scrub in, neither one gets paid. So it's kind of like a forced shotgun wedding, and as a result of that, there's actually been a very good collaboration with the cardiac surgeons. And I think they recognize that the results are getting better and better. Now, when we first started doing TAVR in 2005, the sheaths were very large. There were a lot of complications. We didn't know how to size the valves. There was a lot of aortic insufficiency and valve embolization. So in the infancy of the procedure, there's no way that this could have been available for younger patients. But as the procedure gets more predictable, just like with angioplasty, the devices get smaller, they're easier to deliver, we understand sizing issues better, we're getting better and better at doing it. So I think that it's going to evolve. 2 weeks ago, we treated a 32-year-old man who had a previous bioprosthetic valve, and we placed a transfemoral valve in the patient. He was home the next morning. He was in the hospital for less than 23 hours. So I think that the results are going to get better and better. The one question we still don't totally know the answer is the durability of the valve. We know that a stentless surgical valve will last routinely 12 to 15 years, and we still will not know how long these valves will last. The very first patient that I implanted in the US in 2005 died in 2011, and of a non-cardiac cause. So at 6 years, the family let us explant the valve, and I looked at the valve itself, 6-year-old valve, and it still looked very, very pliable. It didn't look very much different than when it was first implanted. So at least with one patient, I know that the valve will last up to 6 years. So I think we have to be a little careful of offering this in younger patients. A 70-year-old person with aortic stenosis, it still is a little disconcerting to say that it's going to give you as good a result as a surgical valve.
Excelente. También me gustaría, si Daniel Navia, que está ahí, le podemos dar un micrófono. Daniel, si levantaste, acercan y tenés alguna pregunta. Creo que nosotros lo que hemos aprendido en el contexto del instituto es a trabajar en conjunto para ver cómo podemos progresar a que las decisiones sean tomadas sin competencia de quién es dueño de los pacientes.
Yeah.
Pero un aprendizaje que me dio a mí la angioplastia, que la empecé cuando empezó, y esto es lo que ya todos comentan, pero no importa, me gustaría que hagas alguna especulación al respecto. Angioplastia empezó de lo más fácil a lo más difícil. Un vaso muy fácil, después ahora tronco y 3 vasos. El reemplazo valvular aórtico percutáneo empezó de pacientes near death, lo que se llamaría partner, para los que no están familiarizados, el estudio que separó pacientes que ya no había nada que ofrecerles tratamiento médico, y ahora parece que nos vamos bajando a algo más sencillo. ¿Cómo ves que está haciendo esta evolución? Estamos llegando, entiendo tu preocupación de no ir a pacientes muy jóvenes, pero estamos bajando el riesgo del paciente.
Yeah. Well, the procedure is getting more reproducible. We have to think about these things as a 20-year cycle. From the time something gets invented, it takes 20 years for us to understand how to do it, which patients are best suited, and the best equipment. That's the same with angioplasty. Started in 1997. It started in 1977. By 1997, angioplasty was a mature field. We had stents, we had patient selection that was pretty well established. This field started in 2002, and so it's not going to be really for another 5 or 6 years before it's very mature and we'll have a better handle. There are definitely patients that can't be treated with TAVRs. Low-riding coronaries where the TAVR valve is going to occlude the coronary arteries, and other cases where there just isn't going to be a percutaneous option. But the field is not quite at the maturity. My biggest concern right now, and we all have to be careful around the world, is not to make the mistakes we've made with every other technology. And for instance, with stenting, stenting became very easy. We would stent anybody. And so patients that had 30, 40% lesions were being stented, and it became over-abused. It's very possible that we're going to start looking at these patients that are asymptomatic with gradients of 25 or 30 and telling them, well, let's get it fixed now so that you don't have to worry about it later. So I'm very concerned about abuse. It's happened with every other technology that we've done, and this is certainly a possibility here.
Daniel, ¿algún comentario?
No, un comentario es desde el punto de vista de cirujano. Indudablemente esto cuando comenzó desde el punto de vista de cirugía parecía que era imposible que dejando la válvula calcificada se abriera y eso no traería ninguna cosa dramática, no solo del leak periprotésico, sino de stroke, con embolia. Nosotros en cirugía hay una relación muy directa, la dificultad de un cambio valvular con la concentración de calcio en las leaflets. Y veo que eso en la bibliografía o mirando las prácticas y los reportes de toda esta nueva tecnología que es tan apasionante, no ha sido una preocupación. Es decir, y para nosotros en cirugía la relación de mucho calcio, mucha decalcificación, limpiar bien el anillo antes de poner una válvula es una de las variables más importantes por la incidencia de stroke o de incidencia de dificultad técnica. Esto es todo obviado con esta técnica percutánea. ¿Cuál es si esto le da importancia a la concentración de calcio, si la tomografía o MRI puede ayudarnos a ver si las leaflets tienen mucho, si es bicúspide, si no es bicúspide, si el calcio está excéntrico? Porque tiene implicancias en la incidencia de insuficiencia paravalvular y también de la eventualidad de stroke.
Yeah, I think that the worry about stroke is very important. That was one of the biggest arguments that the vascular surgeons had about carotid stenting, that even with distal protection, there still was a substantial incidence of stroke. And I think that is one of the things we have to confront very carefully. And there is an incidence of 1 to 3%. If you look at the literature, it's conflicting. The Edwards valve in their trial against surgery had a higher rate of stroke. The core valve had a lower rate of stroke. So I don't quite know what the answer is, but I think that we are going to be using distal protection, and I think that those distal protection devices are going to make it less and less likely. The problem with using distal protection is that the rate of complications is very low. It would be nearly impossible to do a randomized trial to show that a distal protection device decreases the rate of symptomatic stroke because the rate is so low. And so that's, again, a part of the field. As far as paravalvular leak, I think we've got the paravalvular leak issue solved. The S3 is the latest generation of the Edwards valve, has a skirt at the bottom, which has almost eliminated paravalvular leak. There's also other valves, the direct flow medical valve, also has a skirt at the bottom and also decreases the risk of leak, and other valves that are going to be coming out. So I'm not too concerned about paravalvular leak, but I think stroke still is a very important major issue we're going to have to deal with.
Una última pregunta y después cerramos. Fernando Cura.
Muy interesante el approach de llegar a la válvula vía transcava. Y en un abordaje muy imaginativo, y la pregunta es ¿cuál va a ser el lugar de este abordaje hoy teniendo otros abordajes como el transaórtico o transsubclavio? El abordaje transcava al menos luce muy cómodo desde el punto de vista de cómo trabajar. A veces en estos accesos transaórticos uno se dispone en la sala en forma muy incómoda y no deja de ser procedimientos quirúrgicos. Entonces la pregunta sería, en pacientes que no tienen un acceso femoral, que sería como la primera elección, ¿cuál sería el segundo? ¿Vamos a transapical o la transcava podría ser algo que a futuro lo ve como algo creciente?
Yeah, we have stopped doing transapical implants. And we have an article coming out showing that the 1-year survival is better for transcaval than transapical. And so right now it's a question of transaortic. versus transcaval. And I think that just the advice that I would give to anyone with a sort of a moderate-sized TAVR program is learn one alternate access technique really well. So some people are using subclavian, some people are using transaortic. This other transcaval is something that you could learn. Learn one very well and use that for most of the non-femoral access. Because if you try to do one transcaval and one transaortic and one subclavian, you know, once or twice a month, you won't get very good results with any. You just really have to have a lot of practice. So that would be my advice, is figure out which one you like and just practice and use that one as the most frequent. Right now, with the new sizes of the sheaths, about 15% of people will not have femoral vessels big enough for the newest generation sheaths. So that's not that many. It's a small group of people. So that would be what I would say. As far as the transcaval approach, it's actually pretty easy to learn. And after you've seen a couple of patients, and we worked with a group in Cali, and they've done 12 transcaval cases now. So they picked it up pretty quickly. So it's not that hard to learn.
Muy bien, muchísimas gracias. Damos entonces por finalizado.
Gracias.
Muchas gracias. Thank you.